Hi, my name is Dr. Chris McAdams, a board-certified radiologist and member of the Medical Association of Atlanta's Board of Directors. Through my solo practice, Will-o'-the-Wisp Consulting, I work across Georgia and our neighboring regions, providing clinical and consultative breast care. I'm here today with Dr. Andrew Norton, Chief Medical Officer at OncoHealth, an MAA Platinum sponsor. Today, we are talking about prior authorization, a topic that every physician and maybe even every patient has encountered, whether they know it or not. We will unpack what's working, what's broken, and where technology and legislation may help us move forward, and how it may help with the process rather than hurt. Dr. Norton, thank you for being here with us today. Can you introduce yourself and maybe share a bit of your background?
Thanks so much for having me. It's a pleasure. My name is Andrew Norton, as you said, and I'm the Chief Medical Officer at OncoHealth. I am a neuro-oncologist by training, which is to say that I take care of patients with brain tumors and their families, and I work on clinical trials. I spent the first half of my career or so at Dana-Farber Cancer Institute in Boston, and then I transitioned into a variety of oncology focused technology and managed care roles. And for the last 5 or 6 years now, I've been at OncoHealth, where we help health plans primarily, as well as patients and oncologists with oncology care. We're focused on utilization management and we're focused on care management as well. We'll be able to talk a little bit about our products and services as we go on. But I'm delighted to be here, and I thank you for inviting me.
Thanks, Dr. Norton, and thank you for that background. Let's begin with the basics. For anyone watching who may not be familiar, what exactly is prior authorization, and what does it achieve when it's working as intended?
Well, I usually explain prior authorization very simply. It's just the process by which a patient's health plan confirms ahead of time that something they already cover is medically appropriate for the particular patient. So when it works the way it was intended, it should do a few things. One is it should promote evidence-based care. It's meant to nudge everyone toward guideline and evidence concordant diagnostics and treatments and away from things that are clearly low value or unsupported by the best available evidence. It's also designed to protect patients from unsafe or duplicative care. For example, prior authorization may catch drug interactions or dosing errors or duplicate imaging tests or procedures that conflict with each other in some way. It's designed to match the service to the right setting. Sometimes the question is less about should this be done, but where and how, so that it's safe and reasonably priced for both the patient and the plan. And then finally, it's intended to support affordability and sustainability. Plans generally use prior authorization to keep the very high cost or highly variable services from spiraling, ideally to keep premiums and patient out-of-pocket costs manageable for the whole population. Ideally, prior auth should be targeted, fast, and predictable, and it should focus on a relatively small slice of high-risk, high-cost care that results when needed in a quick clinical conversation, not a prolonged, opaque, or highly complex administrative barrier between you, the physician, and your patient.
I think that's really helpful and provides a nice background for our audience. So, from a reviewer standpoint, what do prior authorization teams need to see to approve a case? And then, what are some of the most common reasons that you see denials?
Well, on the review side, the prior authorization team is usually trying to answer just three simple questions. First, is this the right diagnosis and clinical scenario for the particular test or treatment? Is what you're requesting consistent with the health plan's medical policy or guidelines? And then three, in the setting of a drug, is it the right dose or duration of treatment? And is the setting safe and reasonable for the patient? And so in order to say yes, prior authorization plans that are conducting prior authorization need clear documentation of a few things. They need to understand the diagnosis that the patient has and how severe that is, key clinical data focused on that diagnosis, so maybe labs or imaging. Often the physician's note provides all of the relevant information that's required. Typically, one needs to understand previous treatments, exactly what you're requesting, and the details around that. So which drug, which dose, how is the drug being given? How long is the patient expected to be on that drug? And and then finally, particularly when you're using something that may be out of the box, links to guidelines or policy that supports that use can be extremely helpful and result in a quick approval. So the most common reasons that cases get denied, I would say, align with the fact that we need that information described above. It's much less often bad medicine per se, but more often incomplete information. So the number one reason that a case gets denied is missing or incomplete information. In the case where a physician note is required, which it often is, maybe we see an old note from 6 or 12 months ago rather than the most recent one. Sometimes a denial happens because a request doesn't meet a particular policy criterion. For example, the plan may require failure of a first line option, or a drug may be appropriate when a particular lab threshold is met, and either that piece of information is not provided or does not meet criteria. And I would say this can be frustrating because while the health plans post information about these details on their website, it's not always easy to find, and it should be. Sometimes we see requests for off-label use, and there is lacking supportive evidence. So this can look to the health plan or the reviewing physician as an experimental request. There are scenarios where a request it represents a benefit or setting mismatch. So, for example, perhaps the treatment is being administered on the medical benefit by the physician, but it's requested as a pharmacy benefit. So this is an administrative rationale. And then sometimes there are timing issues, like perhaps it's too close to the time when the therapy was previously authorized, or the request is sent to the wrong plan. Things like that happen. So that's a long list, and maybe I spoke too much, but I think the controllable pieces are about missing and incomplete information, failure to meet policy, or a lack of supporting evidence. And so I think if you, as the requesting physician, think of the reviewer on the other side just as someone who's trying to build the clinical story to understand the rationale, then you know what information needs to be provided in order to get to a quick yes.
Absolutely. Those are all great points, Dr. Norden. Sometimes I found it's instructive to frame the conversation from the contrarian standpoints. If you really wanted to get a claim denied, do all of these things. And I think your summary was very helpful. It gave us some examples of the most common reasons things are denied right out of the box. Let's pivot to the policy landscape. We've seen a lot of legislative attention lately on prior authorization reform throughout the US. For example, one recent piece of Georgia legislation shortened review times and set clearer standards for urgent requests. Another brought the gold card concept to the state. What's your take on these types of laws, and are they helpful?
That's a good question. Georgia is actually a good example of what we're seeing nationally. A number of states have been passing laws that are similar to both of the ones that you mentioned in Georgia. And I do think overall these laws are helpful in a few ways. They generally establish timeliness requirements for health plans, and that allows you as the physician to get some degree of predictability. How long should I expect for a case to be turned around? They also involve transparency, which I think everyone agrees is a good thing, making sure that the criteria health plans use to make decisions are knowable, not just by you as the doctor, but also by the patient and the medical community in general. They generally require continuity for chronic care. There's nothing more frustrating for a doctor or a patient than a patient who's on therapy that's working for a particular chronic illness, switches from one health insurance company to another, and suddenly can't get the same treatment that was working all along. And then finally, I think it's a good thing that these laws generally involve some degree of administrative relief for good actors, for the physicians who consistently practice in a guideline concordant way. That said, there are trade-offs, and some of these aren't so well known or understood, and I think it's just worth mentioning. The first is that many health plans operate in multiple states or even across the country, and these laws are all a little bit different. As a result, they increase the overall administrative burden on the plans, and they can make it challenging for and costly for plans to administer. Another point that I like to highlight is that sometimes the regulations are too rigid. An example of this is even in Medicare, we've seen that time frame requirements for case reviews have been getting shorter and shorter. For the last several years now, if a physician submits a request to a Medicare Advantage plan and marks that request as urgent, which is often the case, then the plan only has 24 hours to make a decision. That sounds good in the sense that you want a quick decision. The trouble is, if the information provided is incomplete, there's only a total of 24 hours for the health plan to reach out to the requesting physician, obtain the relevant information, and make a decision. And sometimes this results in a lack of information denial that could otherwise have been avoided if a little bit more time had been permitted. So that's an unintended consequence. And then finally, gold carding programs that are designed to help out the physicians who generally operate in the right way, which, as I said earlier, is most. These sometimes favor large systems, and sometimes they encourage gaming of the system, in a way that's unhelpful. There's a state where OncoHealth works. It's not Georgia. I won't name the state, but there's a state that has a similar gold carding law. And the trouble that we see is that it leaves some uncertainty as to whether the threshold for good practice should operate at the level of the individual drug or the individual chemotherapy regimen, or rather all chemotherapy. And so as a result, payers operating in that environment are operationalizing the threshold calculation in different ways, and that actually ends up creating confusion and a burden for oncologists who are trying to treat patients, and operating in a scenario where they have multiple different payers. So overall, I guess what I would say is, I think the direction these laws are pushing is positive. They're trying to get decisions made more quickly, more transparently, and reducing the burden on physicians who are practicing in a high quality way. But the details matter, and the consistency of these laws matters. And I'm hopeful that we'll see them sort of come together over time in a way that makes them easier to operationalize than they are today.
Absolutely. And I think your insights are incredibly thoughtful. And I think also it's a good reminder that in the legislative space, progress isn't always linear. Sometimes it's incremental, but incremental progress is progress nonetheless. And we'll continue to monitor and watch how that evolves together. Another area, Dr. Norden, that gets a little less attention, it seems like, is the appeals process. Are you able to talk a little bit about what physicians and patients should know about the appeals process?
Yes, absolutely. Appeals are designed to be a safety net in the system. And in general, I think they operate that way. And they're underused. Um, there are a few key points I'd make that I'd say all physicians who practice in this environment should know. The first is a denial is definitely not the end of this story. As we were talking about a minute ago, many denials are issued simply because of a lack of information submitted or available at the time of the initial request, and then others can be administrative entirely. And so these can be overturned quickly on appeal. And therefore, I think when you feel confident that the wrong decision has been made, a quick appeal can result in a quick reversal. The other thing is there's a lot of regulation that requires health insurance companies to provide detailed denial rationale. And what that means is, though you may be disinclined to read letters that come from the insurance company, as many physicians are, when it comes to a denial, the specific clinical rationale for the denial must be spelled out, and the policy that's being referenced must be included. And if you read that and feel confident that the wrong decision's been made, then a short appeal letter from you that directly responds to that rationale in a point-by-point way often results in a quick overturn as well. Peer-to-peer reviews are really important. In general, a peer-to-peer conversation whether during the initial case or during an appeal, is a good way to get the decision changed if you think it was wrong in the first place. So it's valuable to have the most knowledgeable clinician who's seen the patient take the call, be prepared with the relevant evidence supporting that request, and similarly, in a growing number of circumstances, you as the physician requester are entitled to have a conversation with someone in the same or at least a similar specialty. If that's not happening, you can ask for that. It's also worth knowing that reviews of appeal reviews are hierarchical. So even if an initial appeal is upheld, meaning your initial denial is not overturned, there's almost always an initial internal appeal level at the health plan. And then there are additional levels that go beyond that. And this is true in the large majority of circumstances. So again, it may be frustrating to have to go through this process, and I know that, having gone through it myself many times. But I would say, if you feel like the wrong decision continues to be made, another appeal is worthwhile. And finally, I'd say that in the way I described just a second ago, the value of sort of a point by point denial that addresses what you read, point by point appeal that addresses what you read in the denial letter that you received, putting the story in the context of the patient in front of you in writing can be very valuable. In other words, a letter that says this patient is very unique and the existing guidelines and evidence don't fully apply, and here's why. That's valuable information, whether you put it in writing or you offer it on the telephone. So, bottom line, I would say it's important to know that you, as the requesting physician, and your patient, you have rights in this process. You can ask for more information. You can have a peer-to-peer conversation, and at the end of the day, if things still aren't going right, you can request an independent review that comes from outside the plan altogether. And I'd encourage all of that.
Thanks again for getting into some nuance on the appeals process. I don't think a lot of physicians necessarily know some of that, and it was very helpful to have that context as well, Dr. Norden. Before we shift to the role of technological assists in mitigating prior authorization hurdles, do you have a few additional practical tips that you would offer to physicians trying to navigate this a little more effectively on a day-to-day basis?
Yeah, definitely. Based on what we see, I think I could probably spend a whole hour with you on tips and tricks, but I'll try to hit the high points. I think the first thing to say is that every practice deals with a certain set of requests, whether those are diagnostic tests, imaging or labs or therapies, that always trigger prior auth. And you may have some where approval is not the norm. And I would say in those cases, building a simple checklist for your office staff to know what needs to be submitted or what you need to document and so forth, what data is required to get to a yes can be really helpful. And talking to the plan about that can be useful. I'll say more about that in just a moment. I think clear documentation is more valuable here than in many other use cases, perhaps. And that's to say, if your note explains why a particular test or treatment is required for this particular patient and why now, and even better, if it explains or mentions that treatment or test is consistent with national guidelines or health plan policy or both, that information can help you get to a yes quickly most of the time. When a physician reviews a request, very often they look for the latest physician's note and they look for the first couple of lines of the assessment and plan. That's where we go to find sort of the bottom line. And so if you provide that key summary information right there, it helps you get a yes. The other thing that will help you get a yes is making sure that your office submits complete information. We end up having to deny cases, as I alluded to earlier, where a request includes the physician note from 2 years ago. Or a pathology report from 2 years ago. That information really doesn't add anything to the case. What matters is what's going on with the patient right now, and why do you need this treatment or test right now? So if you can make sure that your office consistently submits your latest medical records, you'll be in good shape. Another important point that I'd highlight is if you're seeing patterns where the same kinds of cases are being denied again and again, and maybe you're unclear on why, you can always call the plan, ask to speak to the medical director, and have a direct conversation about what's happening. It may be that there's a misunderstanding. It may be that the health plan's policy hasn't kept up with current evidence and guidelines. And the only way they'll know and be able to update that is if they hear from you. So it doesn't have to be contentious. Think of it as information sharing. The truth is that health plans just want to ensure, as we said at the beginning, that patients are getting high quality evidence-based therapy. And so helping them see that they may be interfering with that in a particular circumstance will be valuable. The other point that I would say is it's useful to use the electronic tools that are available. Plans today generally have electronic prior authorization portals. Sometimes these integrate with EHRs, which is optimal. And the portals aren't perfect, and they're not all the same, which is a source of frustration, I think, for the whole industry. But that said, they're usually faster, and they usually result in a higher degree of transparency. You can sort of monitor the progress of a case compared to calling and going through a phone tree or faxing in a request. So, to summarize here, I'd say I'm not trying to turn your audience of clinicians into prior authorization experts, but I think if you think about the fact that your note needs to tell the clinical story and explain the rationale for what you're doing, and if you consistently ensure that your office staff submits your latest medical records, you'll get a long way toward fewer denials.
Absolutely. And it's a reminder that we can reclaim a bit of our autonomy as physicians and time with our patients by tightening up that documentation and aligning those standards as clearly as possible and upfront. Thanks again.
Exactly.
Let's shift and talk about technology now. Many physicians and even patients are understandably wary of AI, artificial or augmented intelligence, as some groups call it, being inserted into these processes. And I think what they picture are black box algorithms that are denying patients care. And that's often what we see and read and hear about in the media. But is this the truth? It seems like there could be enormous potential for technology solutions to simplify prior authorization and not necessarily complicate it. Just wondering what your thoughts are on how AI and automation could be applied responsibly in this space.
Yeah, there have been some egregious examples that we've heard about in the media. And I think everyone agrees that shouldn't have happened and shouldn't happen going forward. I'm starting to see some really positive uses of AI, and I share your excitement that it will make jobs easier for practicing physicians. The way I kind of look at this is look at AI and automation generally is it's a tool that should help us strip out the repetitive parts of prior authorization, the administratively burdensome parts, not to replace the clinical judgment piece on either end. So, a few things I've seen that are helpful both on the provider side and the health plan side. On the provider side, increasingly EHR systems are using AI to run sort of a pre-check so that a test or treatment that you're ordering maybe gets run through against the patient's benefit design and health plan policies in the background so that you can know immediately, is prior authorization required? And if it is, what are the criteria? and what information may be needed. I think that that's very exciting as the system in the EHR starts to talk to the health plan systems. And we're going to see that more and more. It's also the case that provider side AI systems are starting to fill out prior auth forms for you in an automated way so that your front desk staff doesn't have to do it, so that you don't have to do it. And I think that we're going to see that getting better and better. On the health plan side, AI is also proving really, really useful. We're starting to see it used for instant approvals for a growing set of scenarios. These are the guideline concordant scenarios where data is pretty clean, and simple rules or more complex rules applied by AI systems are able to give near instant or even instant approvals. And then only bump up cases to a human if the AI is unable to immediately say yes. We're also seeing examples where the AI can figure out the optimal reviewer type to triage the case to. Maybe a particular case needs to go to a nurse who will be able to make a quick approval. Maybe another case is more complex and needs to go to a same specialty physician for review. Again, the idea being to try to get to a quick yes. In scenarios where perhaps there's not provider side software that's pulling out the key elements of a particular case, we're seeing that AI systems on the payer side are increasingly able to read medical records and pull out that information in case you didn't have that available to you. And again, that facilitates review and leads to quicker reviews. And then finally, the most sophisticated health plan side AI systems are using LLMs, just like ChatGPT and others, and these can match the patient and disease characteristics against guidelines, against health plan policies. And I think we'll see that we'll start to get increasingly high auto approval rates on even these complex cases. So from my view, there shouldn't be a scenario where these systems would ever deny care, and in fact, most federal and state laws make that illegal anyway. So, and I think that that's the right thing. We shouldn't have robots denying care. So. I guess for me, I'd come down to sort of three principles. Mm-hmm. One is the automation should really be oriented around reducing administrative friction, not touching human clinical judgment. There needs to always be a clear path to a human reviewer for anything that's nuanced or contested. And then whether a human is reviewing or an electronic system is reviewing, we need transparency into what the review criteria are, and we need to be able to audit against those criteria. So if a system is saying, these particular criteria are met, or a human physician is saying these particular criteria are met, we should be able to go back and look at how that decision was made, what were the decisions against those criteria, in case there are questions or uncertainty. And my view is that if we kind of stick to those few principles, then I think AI is going to get easier AI is going to make prior authorization easier and easier, and it will let humans focus on the small number of cases that really need human-to-human discussion, and all the others can flow through much more smoothly. One other thing that I like to point out is that I think that the problem that we have with prior authorization today is that it's such a blunt instrument. It's typically applied across an entire physician network, across a whole bunch of services. And I really see AI as helping us to accomplish both a shrinking of the set of services where we need PA, and then doing what we were talking earlier about gold carding, which is recognizing that most doctors actually practice in a guideline concordant, evidence-based way most of the time. And so what we need to do is find the minority of physicians, who really need the prior authorization check and balance. It's a small minority, But today's systems aren't that great at finding those people, so it's too burdensome on the community as a whole. And I believe AI is going to make that better.
Thank you for that perspective. I think it's absolutely interesting and fascinating on multiple fronts as this technology evolves, and it certainly is here and now and with us, but also reinforces the concept that physicians need to be at the table and part of that conversation as these are implemented into our clinics and into how we deliver hopefully better care and faster, more efficient care that's appropriate for our patients. So I think it's really inspiring that AI has the opportunity to elevate rather than replace that physician expertise. And that's one of the core messages that I appreciate you bringing forward in our conversation today. And I think also highlighting the fact that physicians are struggling with burnout, and some of that is from administrative loads like prior authorization, and shifting some of that away off of the physicians could absolutely be transformative in terms of that burnout and that administrative burden. Dr. Norden, thank you so much for sharing your insight. This conversation reminds us that while prior authorization isn't going away tomorrow, there are meaningful reforms and tools emerging that can make it more transparent for both physicians and patients. And thank you to our viewers for joining us. We'd also like to extend our gratitude to OncoHealth, our platinum sponsor at the Medical Association of Atlanta, for helping make today's discussion possible. And until next time, I'm Chris McAdams, and thanks for watching.
Thanks for having me.
Thank you.